of your box. As you just heard, we're recording this session as well so that it's available for you all to share for anybody that is not in attendance. And we'll post that right away on our website so that that along with the deck are available. We'll give everybody a few minutes to join. As a reminder, go ahead and put your name and your organization name in chat. I know that Lauren from our team had to step away. Lauren Wood had to step away for a minute, but she'll be back later. We do have a quick, I think we have a link in the chat. We have started a listserv and it is through Slack. So there is a channel. We tested it out a little bit in our last coffee chat, but we'll share that information with you. Thanks so much, Emily. And we'll be able to use that as a way to communicate with each other outside of this monthly meeting. You can use that as a tool to communicate amongst yourselves. If you have other community partners that you need to reach out to, please feel free. We're not policing the Slack channel, but definitely, you know, different things that are happening in the community, meetings, conferences, other work groups, questions that you have that you want to crowdsource. Ideally, that's the whole intent behind the Slack channel. All right, I do see folks are still coming online, but we can go ahead and I think probably get things started. If you're just joining, welcome, welcome. Please make sure you enter your name and your organization name in the chat. We do record the sessions so that they're available at a later date. And we love the video on because we are all virtual and it's nice to see some familiar faces, but it is not mandatory. All right, that said, we are going to do a quick instant replay from last month. And we have a few group announcements and then we have an activity. We'll spend the majority of the time today in our activity, and then we'll kind of talk through next steps for engagement. Okay, instant replay, new Contra Costa Path CPI channel. Let us know how it works for you. We are all listed on that channel as well. So if you want to reach out to any one of us directly and you find that Slack is easier to do that, please go ahead and do that, even if it's just to say hi, or if you're interested in a one-on-one meeting. We had a nice, I think, April coffee chat. We were able to dig a little deeper. So I don't know if anybody remembers last month, we didn't have as much time as we would have liked for the actual activity and the interactive breakout rooms to kind of tease out and talk a little bit about our change ideas. As a result, we scheduled 2 meetings in April, one for the week, I think it was the week after the last meeting in March, and then another one last week to kind of really spend a little bit more time talking about different things that are happening in the community and opportunities for change, things that are pressing, things that are priorities, things that are pain points. And we're going to do a little bit more level setting today. We also reviewed that network provider map. I think we still have a few updates, right, Mariah, that need to be made to that. I think we're waiting maybe on some additional information from some of the managed care plans, but for the most part, thank you to the managed care plans on the line for providing us your network information. I don't know if anybody has had a chance to use that Kumu map, but please feel free to let us know if that's working for you or if it's not working for you. If it's not working for you, we can pivot and look at another way to display the information. Ideally, it was a way to put a visual to the actual network of both the ECM and community support services available in the area. All right. Our CalAIM slide. This is a slide that you're going to see on every one of our monthly presentations. but it's really just a reminder, why are we here today? What are we talking about? Why are we engaging? What's the bigger, broader purpose? All of these different things that we do, the services that we provide, the way that we interact with consumers, patients, people, is tied to a bigger, broader initiative across the state. I think we have 1 or 2 more slides tied to CalAIM. I think they're here in the announcements, but I think, do we have the IPP stuff first, Emily?
No, I think we go right into CalAIM and then IPP.
All right, wonderful. I think we have Sokim on the line.
I don't think she's here, so I can take this slide. Just an FYI that the round 2 for cited funding is now available. The deadline to apply for funding is the end of May. We would love to chat with you all if you're interested in applying for cited funding. If it's something that you have no idea what it is, or if you have questions about the differences between cited funding and things like the TA marketplace, we're happy to set up a one-on-one conversation with you and talk it through a little bit more. I do know that DHCS is, they're really excited for better understanding people who will be applying for round 2 for cited funding, and really looking at kind of that local infrastructure building, which is the kind of the purpose behind cited funding, is really to help organizations get set up to administer or to provide ECM and community support services. So we can definitely share out the link as needed that you see here related to cited funding, but just to plug, it is available. And part of what we want to do as facilitators is really help you better understand what could be available through cited funding, and also think about how you might apply. So all of that to say, definitely please reach out, and we will be reaching out as well if there are organizations that we know of who are eligible or might be eligible for applying.
Thank you so much, Danny. All right, I don't think I saw Dr. Shea. Dr. Shea, are you on the line? I don't know that I saw him here in attendance today, so I'll do a quick update on behalf of CCHP. And then also, Emily, if you can share Cynthia's contact information in the Slack, or excuse me, we'll share it in the Slack channel as well, but in the chat for today, thank you for that. And as that chat mentions, CCHP will be distributing some small grants to their ECM and community supports providers. So the person that you're going to want to work with, if you are interested, is Cynthia, and we've supplied her contact information in the Slack. I do see Tara on the line today, so I'm going to hand things over for Tara to give a quick update on Anthem.
Hi, everybody. Can you hear me before I start? I should be all okay, good. Hello, everybody. My name is Tara Bricky, and I manage IPP's Anthem's IPP incentive payment program. And we started this program last year because DHCS, starting in 2021, 2022, allowed managed care organizations the opportunity to apply and for IPP funding. And I'm going to share my screen in just a second. But the purpose of the IPP funding, there's 4 general areas, and this is where they want us to give the funding. Let me share my screen. Share screen. Okay. Can you guys see my presentation?
Yes.
Okay, good. So I see that there's a lot of managed care plan, or there's folks on this line who already know about the incentive payment program. So I'm going to go through this rather quickly because some of this is probably not new to a lot of you. What you can see here, and this is for Anthem. Okay, I'm not going to speak for the other health plan, but for Anthem, we have 4 DHCS has 4 priority areas, and also Anthem aligns our IPP funding. So the incentive payment program, these dollars flow from Anthem to you, okay? And we want to fund like the delivery system infrastructure. So this could be HIE, this could be your electronic health records, this could be like HIO, things like that. Then we want to fund the ECM provider capacity building. So this is, we want to ensure that the folks in this county have the ECM resources to support them. So we want to bring up providers. Is it staffing? Is it education needs? Is it, do you need any other type of support that an ECM provider might need to either take up a new provider of focus or expand their current provider of focus based on their need? And then we have community supports, same thing. Are there community support? So Anthem is committed to rolling out all 14 community supports. And to do that, there's some providers, local providers today that already do this. There are some community supports that there might not be local providers that do that in the county today, but we want to support contracting with local providers and or regional providers to bring in those services to this county and with all 14. So is that staffing? It could be, helping secure funding for a building or things like that. Whatever we can do to try and support the take up of that community support, we're going to do that. And then there's quality. So if there's any type of reporting needs, any like, I don't know, data management and reporting type of staff you might need, we can help fund that. So DHCS, these are the same things. DHCS has their priorities as well. Again, I talked about the take-up of community supports, building appropriate sustainability and capacity, driving MCP investments for IT infrastructure, bridging the silos, reducing health disparities and promote health equity, and then achieve improvements in quality performance. I wanted to talk about and we talked about PATH. So there are 5, and there could be more now, but these are the 5 CalAIM incentive programs that I know about. So I am talking to you about the IPP program where DHCS managed care providers apply to DHCS, and based on our membership in the county and how well we do on our application, they will then hand down funds to managed care organizations. We can do whatever we want with those funds. We choose to support CalAIM and build in the building and expansion of CalAIM. So that's IPP. And then there's the HHIP. Probably some of you are familiar with that. It's the Housing and Homeless Incentive Program. And again, funds flow from DHCS to the MCPs to reduce and prevent homelessness and ensure MCPs develop the necessary capacity and partnerships to connect their members to housing services. There's PATH, what was mentioned before. And again, so PATH Cited is open, and the PATH TA Marketplace. So if you are thinking about applying for PATH and you just don't know, you have questions here. Oops. There's technical assistance for you. Go to ca-path.com, shop TAM. There's technical assistance to help you apply for PATH Cited. The managed Anthem really would like providers to go through PATH first. DHCS has a larger bucket of money to give to providers than Anthem does. So we want you guys to apply to PATH first, and then whatever the needs are after DHCS has funded you, then Anthem is more than happy to come in and support that. There's a BHQIP, which is a behavioral health quality improvement program, and then there's the behavioral health continuum infrastructure. So I don't know if there's any BH providers on the line, but this is specifically BH focused. So I talked about the technical assistance marketplace. Again, a really great resource. If you have questions like, I want to expand, I don't know where to go, or I might be interested in this. Is this population of focus right for me? This TA Path Marketplace will help you. And then again, as was discussed before, there's the Path Cited Initiative. I also wanted to bring up too, this is another funding opportunity. So there's grants. So DHCS, and it's by law now that specific ECM providers, they need to sign the data exchange agreement. It's called the Data Exchange Framework. I'm going to send this slide deck out, but I encourage all the folks. So right now it is mandatory for behavioral health providers, but this is going to expand to all providers in the coming year or so. There are DSA signatory grants available. So I recommend that if you're a behavioral provider, click and take a look. And if you're not, this is coming near future, so you might as well get ahead. And it's all about the data sharing agreements. So Anthem, IPP. So we want to support long-term capacity and sustainability, support the needs that align with the DHCS incentive measures. So as I talked about before, managed care plans, we need to apply to DHCS to receive that funding. So we also want to reinvest those dollars that we earn back into the community. So based on those DHCS priorities, so we can also get more money in the future to reinvest in those DHCS priorities. We want to support our contracted and potential ECM and CS providers, the infrastructure development, and we want to demonstrate collaboration and partnerships with community organizations. We want to close health-related gaps. We want to connect providers to PATH and other funding incentives so you can braid the funding. So if you have this idea, you know, we want to bring on an ECM population of focus and also then bring on a community support to support that. So like a whole person care approach, you can braid that funding together to create that whole person care approach within your organization. Okay. I want to go through, these are 2023 Anthem funding priorities. So if you are a provider on this call and you are involved in any of these, please contact me. I'll put my name in the chat with my email address, and I want to work with you. And you'll fill out this application and we can get funding right over to you. So we want to support local providers. We want a local presence in the community. We're looking for personal care providers and homemaker service providers who do paramedical services. We need community support respite providers and recuperative care medical respite providers. For ECM, we want to partner with Justice Involved and children and youth providers. The adults, sorry, I'm going to take my hand off my mouse. Adults at risk for institutionalization and long-term care and nursing facility transitions. Individuals with developmental disabilities, and then birth equity population. If you know of an ECM provider or you are that type of ECM provider that supports those populations, please reach out to me and email me, and let's get talking. And then also, we want to support providers who utilize community health workers and doulas. And if you're a provider that did not receive IPP funding in our round 1 in 2022, or you have not received DHCS PATH cited funding, or you specialize in serving diverse or underserved populations, we want to work with you. We want to partner with you. We want to support and bring funding to you so you can support this community. So here's the process. So I would like you to reach out to me if you want to participate and apply for Anthem's IPP funding. We will we'll review that need, and we'll do a preliminary review of that request. Then after we review your request, if it meets our needs as well and the needs of the community, then I'm going to send you an IPP application, our program description, our the contracting documentation that you're going to need in order to receive IPP funding dollars. And then you'll fill all that information out, you send it back to me. I'm going to do another internal review, and then I will send you the outcome email of, you know, was your application approved or not, or you know, the details, if we could fund the whole thing or partial, just depending on the amount of money that Anthem has. I'll tell you that the Anthem receives funding from DHCS based on the membership size in the county. And in this county, our membership size is rather small. So we don't have a large amount of money, but the money that we do, we want to reinvest it in this county. And that's about it. Does anybody have any comments or questions for me about Anthem's IPP funding? Okay.
If anybody does at a later date, please, we've shared Tara's contact information. You can also connect with us or through Slack. I did just see a hand raise, but my screen cut over. Does anybody, whoever's raised their hand, feel free to come on off mute.
That was me asking for contact information for Tara, but I see that you've already shared it. Thank you.
No problem at all. And once everybody's on that Slack channel, you can also connect through there directly, or feel free, should there be any issues, circle back and let me know. All right, we wanted to also spend a little time, and we'll try to continue to do this throughout the year. Just kind of talking a little bit about each of the organizations that participate in this PATH CPI collaborative, and really quick, just kind of an overview of the organization, the services that they provide. Are they ECM? Are they community supports? And so today we're highlighting two. The first is 18 Reasons. So we have Claudia on the line.
Hey everyone, I'm Claudia. I'm the Director of Operations here at 18 Reasons. And yeah, we are a nonprofit cooking school. We're based in San Francisco, but we work in Alameda, Contra Costa, and San Francisco counties. We offer free Cooking Matters and or 3 free community programs. One is Cooking Matters, one is Nourishing Pregnancy, and one is Food is Medicine, which qualifies under our CalAIM Community Supports contract in Contra Costa. Our classes are nutrition education classes paired with hands-on cooking. So all folks that participate in our classes get to pick up a knife and practice making really good food for themselves. We also provide groceries with all of our classes. So there's sort of a low barrier entry to trying new food, trying new ingredients. These classes are all facilitated by Pure Health educators, and those are community members that have been trained and we employ to teach those classes in their neighborhoods and in their languages as well. And then, so like I said, currently our Food is Medicine program is a community supports collaboration that we have with Contra Costa Health Plan. We partner with Contra Costa Regional Medical Center to provide food distribution, and we pair that with, again, nutrition and culinary education, specifically for folks that have poorly controlled diabetes. These classes are all facilitated on Zoom, and so we do grocery deliveries on a weekly, bi-weekly basis, and we have CCRMC staff, so doctors that are join in the classes and can answer medical questions that any of the participants may have. So it sort of also creates a better relationship with the doctors than being in that clinical setting. We are looking to expand this program and grow this program with other healthcare partners. Right now, we're specifically working with Contra Costa Regional Medical Center, but we are open to work with other patients that qualify under Contra Costa Health Plan, whether it be at other clinical settings or also in other counties. And then a little bit about our Nourishing Pregnancy program, because that would qualify under ECM, although we don't have an ECM contract with any health plan. Nourishing Pregnancy is a cooking and health program that serves specifically Black and Latinx birthing parents during their last weeks of pregnancy and their first weeks of postpartum. Over 16 weeks, participants can take prenatal cooking and nutrition education classes. And then in the postpartum series, those ones are support classes that build relationships and support networks that will last beyond the pregnancy. So all of the participants receive free groceries during the duration of the 16 weeks and get to hear and listen about just different programs or different resources that are available to them in their postpartum period. So speaking to doulas, sleep consultants, folks that are in the birthing work fields to just provide support for those families in that really critical moment in their lives. And yeah, like I said, we're hoping to expand our partnerships within Contra Costa and to add additional healthcare providers. Also hoping to expand our programming to go beyond just diabetes focused as it is right now, and hoping to expand to pediatric obesity and congestive heart failure in the next few months. And then also expanding our programming beyond the Contra Costa, since we also work in Alameda County and San Francisco County. We're open to subcontracting as well with other Cal-AIM community support providers. If you are a food provider and are missing an educational component to your food distribution, we are very happy to partner with other folks that are doing similar work. And then I can put in a SurveyMonkey link here if you're interested in partnering with us or just hearing a little bit more about what collaboration might look like. I'll drop that in here. And then I can also drop my contact information and then also the contact information for our community programs director, Francesca, who is unable to join today.
Claudia,
And
thank you so much for that. I really appreciate it. We'll also take this information along with the information, Tara, that you provided, and we'll make sure that we reshare that when we send our email blast post-meeting, and we'll also push everything through that Slack channel as well.
Great. I can share also just the slides in the Slack channel.
Wonderful. Thank you so much.
Sure.
I'm going to hand the mic over to Lene now. Lene, are you here on the line? I see you.
Yeah, hi everyone. Thank you. My name is Lene Alban, and I am the program director for our ECM program here in Contra Costa Public Health. We are our ECM program. We sit within our Contra County Health Department and within our public health department. We have been contracted with CCHP to provide some ECM services. We also provide 2 other community support services as well, which I will share with you. We also were previously a whole person care provider, so we're kind of in that unique situation where we transition our whole person care population into ECM if they area. So our capacity, our enrollment capacity here with the ECM provider is 3,700. We are currently accepting more patients as we're not quite full time. Our ECM program is a multidisciplinary team of mental health clinical specialists, substance use counselors, public health nurses, community health workers, homeless services specialists, and social work. So we have a variety of different disciplines that are performing those ECM. Our services are in-person case management that we do monthly, if not twice a month, and our max caseload is 50%. We have a unique resource within our program, which is eligibility workers that we have that work on site for us, and they support with our Medi-Cal retention, so making sure people stay on Medi-Cal, and then also with other public benefits we have throughout the county. We also do all of our documentation within our shared EHR. So all of our documentation is visible to all of the providers within our network. And we also have access within that Care Everywhere system. And luckily here, we're fortunate enough in the Bay Area that many of our local providers and local hospital systems are on the same Epic EHR. And so therefore we have access to share that information. So our ECM case manager contact information and program enrollment is listed in the Care Everywhere screen so that local and hospitals can see our information and contact information. And then On the other end, it allows us to be able to get alerts within our system if someone does get admitted or into a local hospital or goes to the ED, so that way we can follow up with the patient. So a little bit about our community supports. We do provide housing navigation and then housing tenancy community supports within our public health department. We do currently only provide those services for those who are enrolled within our ECM. So that's a little bit about our services. And I wanted to make sure I stay within the time gap, and it also allows some time for people if they have any questions. I know we can talk around with that. If anyone has any questions about what we're currently doing or any more details, happy to share them.
Amy,
Yeah,
I
I'm
see
just,
your hand up.
well, I was trying to be nice and not just shout. So Lynette, a quick question. You cut out when you were talking about your capacity.
Oh, sorry.
That's okay. How many people are you serving?
We are serving our current capacity, enrollment capacity is 3,700.
3,700
Correct.
for ECM.
3,700. Yeah, correct.
Okay. I thought maybe that was like, I heard that wrong when you said it the first time. So I just wanted to make sure.
Yeah.
Thank you.
Any additional questions for Lene?
Lene, hi, this is Jody with Sutter. I was wondering if you could expand upon the interface with our Sutter Epic and how that was set up. I'm in multiple of these CPI collaboratives, and this has been coming up about how folks can link into our Epic system. So I'd love to be able to share the process of how Contra Costa Public Health was able to get that information so that you could see admits and discharges and transfers and whatnot.
Yeah, I'm gonna, we have one of our quality improvement managers on the line as well, Allison Stridling. So I don't want to be on the spot, Allison, but do you have any insight on kind of that build and what we did to move that forward?
Sure. Hi, everyone. Allison Stribling, work with Lene really closely. So we leverage adding our case managers to the care team within the EHR, and then there's a Epic-based notification setting that allows them to receive any alerts for admissions or ED events from shared via Care Everywhere by our systems. It's only allowable if we have the relationship type of PCP was something we learned. So we worked with our informatics team to come up with like an acceptable terminology that would be visible within our care team. So we're listed with a relationship type of PCP, but it's very clear that we're a case manager. And that allows us to get access to the notification shared via Care Everywhere that would otherwise only be sent to primary care providers. And then otherwise, we just, in working with some of our local hospitals, encourage folks to look within we talking within the Compass Rose module within Epic, and that is now shared via Care Everywhere. All the episode information is shared. So we do some education on how to go into the Care Everywhere activity and then pull down Contra Costa Health Services episode sharing and view all the information on our enhanced care management. Hope that helps answer.
Thank you so much, Allison. We have your contact information. Are we okay to, if anybody has any questions, especially with regard to the Care Everywhere?
Yeah.
Okay. Wonderful. Wonderful. Alana, I see that your hand is up.
Yeah, just a quick question for both of the presenters. I was just kind of curious if either you could kind of uplift some lessons learned. I know Contra Costa Public Health is, with the whole person care model, started from there and kind of now they're here, but specifically in relation to kind of like outreach and engagement with members, and if there's anything that you, from like a staffing perspective or just kind of different modalities that you utilize as far as helping with outreach, I'd just be kind of curious to kind of see if there's been any best practices that you've started to identify and kind of lean on to support some of those efforts, just for the benefit of some of the other folks that are on the call.
Yeah, I think that's actually a great question. And Alana, to your point, we are working on improving hours that we already have. But some of the things that we leverage is we here in Contra Costa County have a data warehouse that stores multiple and software systems. So one of them is our homeless management information system, which Michael Fisher is online and he works a lot in. And we do have a data sharing platform with them. So we are able to see if patients are in shelters, for example, like those who don't have active phone numbers, so we're able to contact them through their shelter case managers or the main lines of the shelters, because we're able to identify if they are in those shelters. And we also are able to utilize that team and the HMIS system to get any additional contact information for those experiencing homelessness especially. So those are some of the things that we've leveraged within our county that's supported. The other thing that we're looking at is really doing some more in-field outreach, so in-person outreach. We're currently doing a pilot of getting people out there within the first week of their contact, so they make a couple calls and then getting out into the field to meet those patients. So we're actually just started that pilot this week, because we were historically doing it where they contacted them for the first month via phone, text, those different resources, and then would go out after that. And we're trying to kind of move that up higher, so that they're not sitting in that outreach phase as long, so that we can get them experience. So that is one of the main things that we're working on right now in piloting, and so we're hoping that that will show to be fruitful, and we'll definitely share, what that looks like as we continue that pilot. We are hoping to learn a lot of good things.
Thank you so much for that, Lene. I think, Alana, too, what we can do is crowdsource that question too on the Slack channel. I'd be really curious to see sort of collectively the responses that you get from different providers. So if you don't mind, if you want, you can share that with everybody, or we can go ahead and just push that out through that Slack channel as well. I'll be really interested to hear from folks, both those that are participating today and the rest of the folks who are unable to join us today, to get some of that feedback.
Yeah, and then I can also share a little bit. We've had, like I said, we're lucky to be partnered with Contra Costa Medical Regional Center, and the doctors there are just pioneers of this program. They're so excited. We're lucky that they also want to be involved in the classes and participate in the classes, but of course that's not necessary. But I think just through that network, they are communicating about the impact that they're seeing in their own patients. They're sharing out instructions on how to do referrals, how to refer into our program. And I think that is sort of the barrier to entry, is the referral, making sure that the correct codes and the correct provider is listed. So I think that has been a little bit of a learning curve, and something that we can take on, or we can also provide training materials to providers on how to do that correctly. Something that we are hoping to expand into in the next year or so is sort of that direct patient outreach. Like I said, we work with peer health educators who are out in the community and can connect with folks. And so that's something that we're hoping to roll out in the next year or so.
Thank you so much. Thank you, Claudia, and thank you for presenting today, Claudia and Lene. We're going to move into our activity, but we'll definitely continue on this share out throughout the year. And so for anybody that's interested in doing this from May, reach out to us and let us know, and we'll make sure that we continue this spotlight for our service providers each month throughout the year. Okay, so we're going to go ahead and get into an activity today. We're about 4 months in to the collaborative. I can't believe it already. I don't know what happened to January. But just kind of really quick, we've got about 8 months to do all of this amazing work that we want to get to. And we've talked in those 4 months about different things. What is our goal? What are we aiming to do? How can we frame that work? And so we kind of moved from that into a little bit of a structure to do some of those things. And I think we want to take the time today to really reflect on that information and the work ahead of us, We're going to hand things over to Mariah and to Lauren, who are going to walk us through that exercise today.
Hi, everyone. So like Denise said, I just want to give a little recap on some of the things that we've talked about so that we can set the stage for going forward. So in January, we had our introductory meeting and we went over to what PATH is and the introduction and kind of the stuff that we will be doing. And then so we also talked about how implementation of eSIM and CS services with the new Cal AIMS is going, and so that we can use that as for our basis for where the PATH collaborative could support you all. Then in February, we worked on identifying the provider map, which is how we built the Kumu map. We did a QI breakdown to give you more of an understanding of like our approach to coming up with like ideas to help create some change in Contra Costa. And then we also did the collaborative brainstorming for goal setting, and so that we could set our goal for this collaborative. In March, we did a bunch of brainstorming like action steps, which is what the activity did with the Google Sheet, so that we can get all of your perspectives on the things that you kind of want to work on through this collaborative. And then some of the things we did outside of our monthly meetings is we had some informal coffee chats just so we can all get to know each other. We developed the provider network map that has the services that each plan offers and the contact information for individual organizations and for the plans. And then we have been sharing Cal AIM resources with you all through our website, and now we're going to be doing that through Slack. So now I'm going to pass it on over to Lauren. She's going to give an introduction to herself and this next exercise.
Thanks, Mariah. Hi, folks. For those that don't know me, my name is Lauren Panaccio, she, her, pronoun series. I have the pleasure of partnering with Intrepid Ascent, but I work for an agency called Health Leads, who used to work in Contra Costa County back in the day. What up from Richmond, my little corner in my house here. But really excited to be in this conversation with you all and excited for what we're about to dive into. To Denise's point, you know, we're 4 months into 8 months. We're here because we collectively think that Cal AIM can help turn the curve on health and health equity. We think that working in collaboration with one another, I presume you're not here just because you guys have 90 minutes of your day, right? Like I presume you're here because you think that through this collective action and working in partnership and collaboration with one another, we can really turn the curve and use all these opportunities ahead of us. And at the 1/3 mark, yes, I mathed right. At the 1/3 mark, we want to do some reflection of where are we around what have we been doing and what do we like, wish, and wonder about our approach to implementing ECM and community supports so that we have a chance at reaching the draft AIM statement that you all have worked through. So again, this is reflective. We're going to use this reflective dialogue. Let me pull back the facilitator map for a second, but we'll use this reflective dialogue to inform next steps in 2 ways. One, next steps for Intrepid Ascent around how do we use this space? How do we continue to get better and hone and refine, use this space so that this space can help us all take action towards that aim? And also, what are the ways in which we are able to take collective action and really start to think about what are the changes we want to make and how do we as a collective, either collective within our organizations or collective in partnership, work towards those changes. So we will be using this information iteratively to make changes both to process here and also process in this room, and also the processes that we'll use to arrive at our AIM statement. Let me introduce you to this framework. I like, I wish, I wonder. It's wicked easy. What do you like? What do you wish? What do you wonder? Everybody's got opinions. It's a framework for us to give our opinions. What is a like? A like is a yes, I like that. I want more of that. I want to continue that. I wish is meh to no, right? I wish there were changes. I wish we stopped doing something. And I wonder is it's an authentic question. Don't be overly polite and frame your wishes as wonders. Just make it a wish. Wonders are authentic questions that you really want to chew on together. And so whoever's sharing the screen is showing how we'll access this tool. I'm going to pass it now to Emily, I believe, to just help us understand how to use the tool in front of us to capture this thinking.
Yep, it's me sharing the screen.
Thanks, Em.
So basically, this is a lucid chart. I just shared in the chat how you can join it. Just click the link, enter the join ID, should be pretty simple. And then for this activity, you guys can use these sticky notes and just highlight them on with your mouse. You can double click on them, delete the text and write you know, whatever you like, you wish, you wonder, and then just drag it to your spot where you want it. And then there you go, and you can go ahead. And if the little post-it notes run out, you can always grab some stickies from over here and just drag them to where you want. Does anyone have any questions?
That join ID didn't work for me.
It's not working for me either.
Let's see. Enter join ID. I'm going to test it right here. Share. Join
Oh, it's not
ID.
working for me either, Em, but it works like 45 minutes ago.
Oh, I wonder if it expired. Here, let's try it again. Try that ID.
B is in Victor, 88. CCH is in Henry. Do we have success?
I got in.
Yes.
All
Oh,
right.
thank God.
Copy that.
You got it,
Thank
Em.
you.
Thank you. Cool. Awesome. So hopefully this Em has worked really hard to make this easy for us. We want you to focus on the content and not like, how do I get a post-it? So what we're going to do first and foremost is we're going to like kick it old school and have some quiet reflective time. So go off camera, do what you need to. I think there's about 20, a little under 20. I really want everybody to put at least one I like, I wish, I wonder, which means like there should be like, it should be popping. There should be like 60 post-it notes on this thing at the end of the day. So we're going to give you 5 minutes. We'll give you until math, Lauren, 10:54. We'll give you till 10:54. Again, go off camera if you would like, add your likes, wishes, and wonders. And then we'll come back and we'll discuss what's on the board together. And I have the timer started, so you'll hear from me soon.
Hear that music.
We do hear that
Denise, you're
music.
muted.
just under a minute left, but I appreciate all the thoughts on the board. Keep going. Cool. Awesome. I had to make more Post-its for you all. First off, how was that? Thumbs up, thumbs sideways, thumbs down. Did it feel good to take a beat? Yeah. I love this framework. Please use it. It's not mine. It's very easy. We all have opinions, right? It's a great way to bucket our opinions. Very cool. I will say I helped somebody move a Post-it note. So if you had a Post-it note south of the chart, I had your back and I moved it to the wonders, lest you think it have disappeared. Cool. So from here, we want to break you up into small groups and do some voiceover. And in the voiceover, what we really want to do is, by all means, first off, introduce yourselves, as always. But we also want you to take a look, like this is qualitative data we have, right? We have some ideas on what we should continue doing, on things that should change, and on authentic questions. So we're going to break you out into small groups. By all means, use your I statement, say, I added these things to the board. But moreover, we're going to be in those rooms for 15 minutes. We want you to pull back and look at the whole data set. What are patterns that emerged? Are there any ahas on the screen for you? Is there anything that's on there that you're like, oh, if I didn't think about that, but that's a great point and it makes me think about these other things. We want to use these breakout rooms to like really engage with the information you all just contributed to. So again, introduce yourself, give voiceover on any of the items you added that you want to make sure to uplift. If there are any patterns you're seeing in each of these buckets, and then if anything on the screen generates new ideas, feel free to identify those, and also feel free to add more Post-it notes in these breakout rooms too. I'm conscious of time. I think we'll be in those breakout rooms until 11:10, so just under 15 minutes, if that works for folks. And then we'll come back and share out and talk next steps. Do we understand the assignment? Importantly, the entire facilitation team is going to hang back. This is your space. Talk amongst each other. We're going to hear you in the big room, so it's not like a secret because we can't help you if you keep it a secret. But for the small breakout rooms, we're going to keep y'all to your own devices and talking amongst each other. So with that, I think you're good to release folks into breakout rooms. Cool. Have fun.
Great job. That was fun.
Really, really amazing. I think the group was very receptive, and it was.
How many referrals are we going to get? How much more capacity do we need to build? But also figuring out, if I'm maybe an ECM and I want to provide community supports to my clients, then who's available to provide those supports right now, who actually has the space and is in the geographic area providing the support that's needed.
Yep, I appreciate that. Claudia or James, do you want to add anything from what Rachel offered for your group? Other takeaways from you two?
No, she summed it up really, really well. Thanks, Rachel.
Awesome.
Yeah, great. Thank you.
Cool. Alrighty, I'm going to call in group 1. This is my way of demonstrating that when I'm facilitating, no number is safe. 1. So that's Dr. Sonia, Sarah, and Alan. Curious how your conversation went and any themes or ahas that you all discussed.
I can just list off a few things that were discussed in the conversation and then open up to my my room friends in the room if they want to add anything else. I think kind of similarly to what was discussed, just about referrals and kind of understanding who's providing what services. So just ensuring, directories are available and people are aware of those. And yeah, then also just aware of the referral process. One thing that I did have a question about was just kind of like understanding who's not in the room, and how that impacts awareness about CalAIM and the importance of building that awareness in order for there to actually be fruitful referral systems outside of those that are already contracted providers, because we know that individuals encounter there's various points of entry in which they could kind of be appropriately referred to services, and being able to appropriately identify those would be really worthwhile. I think there was also just conversations about pricing guidance and the need for that to be updated. So just wanted to uplift that. Obviously, that's a little bit more of a DHCS kind of thing, but important to discuss nonetheless. And then I think also with respect to data systems and just how to maybe, kind of collate or identify opportunities to maybe kind of see who's using what is out there, if there is, kind of best systems, and because it sounds like there's a lot of individuals kind of utilizing figuring out different systems that work for their own organization, but is that the best way, and also for opportunities for integration down the line. Sarah, Sonia, anything else that I missed?
You captured it all, and yeah, you did a great job with it. It's basically just, we've been going over what resources, and yeah, like Alana said, it's making sure that we know who's at the table and being able to share those resources and what is in existence as far as services.
Yeah. Awesome. Oh, I said Alan, I'm sorry. I need a better prescription. I meant Alana. I don't know if they're on the phone anymore, but I will just name. Oh, that's embarrassing. Cool. All right, group 2. Well, before I move away from group 1, Alana, thank you for uplifting that. I really appreciate it. And one of the things that I saw in some of the wishes were some sentiments around not just pricing guidance, but also why is there a competitive process for these funding opportunities? How do we gain access to these funding opportunities? I think I saw a few post-its that said that. I wasn't sure if that came from group 1, group 3, or group 2, but it seems super consistent with what you were bringing up, Alana. So wanted to test the connections between those things, and then see whoever added those post-its, if you wanted to add voiceover to those sentiments.
Sarah, I would punt that over to you, I think, as far as from group 1 response.
Sorry, my mouse isn't working. Sorry. Technical issues. I'm sorry, could you repeat the question?
I was trying to see, so Alana was bringing up guidance on pricing, and there's also some wishes that are multiple ones that are talking about access to these grant opportunities that are CalAIM sanctioned. And so I'm trying to see how those things interacted in the conversation at all.
We didn't really touch on those, except to nod our heads and say that the pricing guidance needs to be updated for 2023 California levels. As my understanding is, the pricing guidance is based on 2019 levels in North Carolina, and that's just not appropriate for California in 2023. And, it's interesting, in different counties, people are being offered different amounts. Maybe even within Contra Costa, people are being offered different amounts for the same services. That seems wild to me. And I know there's an antitrust issue there, and we're not allowed to like ask other vendors what they're getting paid, but are different vendors getting paid different things for the same service? Why are folks in Sonoma County getting paid so much more than people in San Francisco, in Contra Costa County? That seems wild to me. And then the grant stuff, like, I don't know, like everything with CalAIM, my attitude is like, everyone's doing the best they can and it's all gonna work out in the end. But like, why were we providing services for a year before we were offered any IPP funding? Like what? And why, like, what's going on with IPP? Why didn't we even know about it? And then past cited, just like, why is past cited a competitive grant process? That makes no sense. If you're providing CalAIM services, you should be getting past cited funding. You need the infrastructure to provide the service. Why don't you just get the money for the services that you're doing so you can build the infrastructure? Why are we competing? It doesn't make any sense at all. And I know, like, I'm preaching to the choir here. Y'all know this doesn't make any sense. We can't do anything about it, but like, whose idea was this? What were they thinking?
North
Like,
Carolina consultant, Sarah, obviously.
it's those consultants.
I don't know that it's true, to be clear.
I mean, who knows? Who knows? I think I often have this feeling in Callan, like we're kind of like parachuting into the middle of something that's going on, and we're like always trying to catch up and be like, wait, IPP, like what's that? Pass cited, HIPAA, what are you talking about? And we're getting a handle on it, and it's all gonna work out in the end. And I'm confident that like a year from now, we will have some pass cited funding to like build the infrastructure that we need. But there's a lot of building the plane while we're flying it that I feel like could have been done way before this all happened, especially around IPP funding and pass cited. And then the pricing, like I've been part of a lot of meetings where people are like, here's how to negotiate pricing. And like when we try to negotiate pricing, the health plan is like, LOL, no. So what are we supposed to do with that? And like, when will the guidance, I think the guidance needs to be updated at the state level to force
setting a precedent.
The counties have to be forced to raise their pricing, which like, I get it. If I was the county, I wouldn't want to offer more than the minimum either, but we need more money. And I know that's especially true on the housing side. Like for food is very flexible and it's smaller amounts of money, but like you can't hire people to run a sobering center if you don't have the money to do it, and that needs to come up front. So I don't know a lot about housing, but I know that's definitely true. So I don't know, everyone needs more money, but we just have to believe that it's going to come at some point.
I appreciate that. I also think I want to make sure we boogie over to group 1 facilitation team. I'm going to take to 11:26. I promise that's it. But I wanted to, Sarah, thanks for giving that voiceover. We are starting, like even in some of this dialogue, we can start to imagine what are the ways that we can use this privileged space to try to be a catalyst to some of these issues. We're not making decisions here. We're not going to get to that conversation today, but I just want to remind us that we don't just have to, I am not a believer, I'm a doer. So, and I don't know if there are others like that in this group, but we are in a privileged space to be able to do in this collective. So let's think about that. With that, I will call in group 2, I'm sorry. And I don't remember who's in group 2. Aha, there it is. Anna and Hector. Any voiceover from your group? Patterns, ahas, soapboxes, which I'm a fan of too.
Hi, good morning. This is Hector Medina with Serene Health. We had a very, very good conversation about the relationship between an ECM referral to a CS and how we can collaborate back some of the data that we give to the CS that comes back to us so we can better frame it into our systems to better serve the health plans data that they need to get back to back to the Department of Healthcare Services, which is something that we really haven't really touched on in my opinion. Anna was gracious enough to inform me how when they do the food insecurity, they have a dietitian. That assessment that the dietitian does would be wonderful for us to have and be able to put back into our EHR system to be able to measure outcomes in that particular arena as well, to make sure that the patient is progressing on the needs that they have. Once they've gone from A to Z, then we can move on. But these are all things that really are in the infancy stages still. Integrating ourselves with the CS providers in our community is very important to us, because that's data that can help us to help the members and to give the health plans what they need as well. And I think, Anna, their open hands system, it works. I think it's gracefully will work wonders for us, because they can provide data back to us and we can then have a better understanding of the members' need as we go forward and establish some kind of parameter to be able to gauge that on what the outcomes are coming up for just on the specific CS services. I think you're on mute, Lauren.
I'm trying to talk and not being able to. Yes. Thank you, Hector. I so appreciate that. And I also love the I don't want to use the word juxtaposition because they're not at odds, but the conversation group one led us through was really high level, right? Of there's some root cause infrastructure stuff as it relates to funding and access and capacity that we need to address. That is true. And what Hector, you just showed is what are ways in which my organization, what are these small changes that we can make? And it's a both and, it's not an either or, but I just appreciate that very naturally in this conversation, we're arriving at things at different levels of the ladder of abstraction, which I shouldn't have said that, that's unnecessary. Things that are at different levels of lift. Anna, I don't know how you like to pronounce it, I'm sorry, but I saw you give the thumbs up. Is there anything you'd like to add from what Hector offered?
No, I think that was great. Thanks, Hector.
Awesome. All righty. I was given till 28, so I didn't make false promise. The promise just changed. So just as a wrap up, this was a great conversation. Thank you so much for participating and leaning in. Like I mentioned, we're not here to just pontificate or think or get on soapboxes. We're here to change actions. What will be coming next is some generative discussion with okay, with this as a foundation, what can we do? And to the point that I just named, doing could exist at a high level and doing can exist at a micro organization practice change level. It's going to probably be a both and. So more to come on that process. We'll use something called How Might We's as a tool to help us imagine that. But with that, I cede my time and I give it back to you, Denise. It still says 28.
No, it's perfect. We only have, if you want to go right over to the next slide, I just want to kind of echo some of Lauren's comments and really say thank you to this group for hanging in and for being active partners. I think that doing this work is important and not necessarily having a way to validate the work that's happening and the needs that the community has makes any work that is done or that how might we or what should we or how can we really difficult. So I really appreciate you guys taking the time and being so engaged today. And I just wanted to share next steps. Our next meeting is May 18th. We'll send, like we do, a feedback survey, and we will send some additional information over via email. And then we'll also start leaning in to the Slack channel. I know email is not everyone's best friend anymore, so Slack is really going to help us, I think, probably communicate in a more engaged fashion. So thanks again for participating. I hope you have a great week, and I look forward to continuing the conversation.
Thank you.
Have a wonderful day, everybody.
Have a good day, folks.
Thank you, everyone. Have a great day.
Lauren P, shout out. Thanks so much. This was really